Good morning, everyone, and thank you all for joining us at the Public Safety Solutions for Substance Use Disorder ECHO, brought to you by Center for Substance Use Training and Telementoring, CSTAT, and Beeville, Texas. My name is Shreya Prasanna, and I will be facilitating today's discussion. A few quick housekeeping notes before we begin. These sessions are enabled for live closed captioning. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. To help us with attendance, please enter your name, email, and affiliation into the chat. To access the chat feature, please click on the speech bubble icon on the navigation bar at the bottom of your window. To all the Beeville, Texas providers, please make sure that you identify yourselves during this session by entering your information into the chat, or if you're joining via phone, please email your name and phone number to beeville@beevilletx@utisca.edu. Please note that we are recording these sessions for later distribution through the Beeville, Texas YouTube channel. Any information you put into the chat will not be shared in the recording. We encourage everyone to join by video, especially for the discussion portion of this session. That said, regardless of how you're joining us today, we're just happy you've shown up here to learn alongside us. Please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is at the bottom left of your Zoom controls. If you've joined by phone, just press *6. You can also use the reactions menu at the bottom right of your Zoom screen to raise your hand and indicate that you have a comment or question to share. You can also use the chat to share your perspective. There's a lot of us in this space, so please keep your comments brief to allow others to speak up. And finally, please note that no protected health information is allowed in either the chat or the discussions, and this includes names, emails, addresses, dates, pictures, or any information that can easily identify an individual. Towards the end of the session, the Beeville, Texas team will send out a link to an evaluation survey. Please fill it out for a few reasons. It gives us your feedback on how to refine and shape these sessions to address your priorities and needs, and allows you to access free continuing education credits. We are approved for CEs for paramedics and any public safety professionals with a behavioral health degree. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Today's session will start with a presentation from Brandon Del Pozo on best practice guidance for post-overdose outreach. Following that, we'll hear a case presentation presented by Vanessa Fierce. There are a lot of professions presented here today, a lot of experiences and perspectives. I encourage you all to share that during our discussion so that we can all learn from each other. And with that, we will do some introductions. Brandon.
Hi, this is Brandon Del Pozo. I'm an assistant professor of medicine and public health at Brown University. Prior to that, I was a police officer and chief of police for 23 years, 19 in the New York City Police Department and 4 as the chief of police of Burlington, Vermont. My research interests, as funded by the NIH, include all sorts of, basically the intersection of policing and addiction and overdose.
Thank you so much for joining us. Jeremiah.
Hi, everybody. I'm Jeremiah Gulka, Executive Director of the SHIELD Training Initiative. We provide occupational safety and health training for police, first responders, prosecutors, defenders, and more on looking at the connection between occupational safety, health, stress, burnout, and the overdose crisis, and ways to find win-win solutions that work for everybody.
Thank you so much for joining us. Vanessa Fierce.
Hi, I'm Vanessa Fierce. I'm with the Department of Behavioral Health. I am the Substance Use Disorder Program Coordinator working within the Jail Diversion Program.
Thank you so much for joining us today. Andrea Hepler.
Hello, everyone. My name is Andrea Helder, and I'm one of the program coordinators here at CSTAT. Thank you.
Thank you. And with that, we will begin with our didactics. Taylor, if you could please share the slides, and Brandon, you can take it away whenever you're ready.
Yeah, thanks. Great. So this is going to be about 20 minutes of training on the idea of post-overdose outreach. I know that the National Institute of Justice just set aside about $1 million for looking at ways to improve post-overdose outreach, especially its intersection with children in the home. So I know some folks on this call have applied for that grant. It's exciting times that this is getting funding to push the limits. To be clear, the didactic I'm about to give you comes from another tranche of federal research funding. Pronto is Partnerships for Post-Overdose Outreach. Could you go to the next slide, please? These are we'll talk a bit about the learning objectives, and then we'll go ahead and get into where the Pronto stuff came from, give credit where credit is due. But we're going to define the purpose, structure, and varieties of police post-overdose outreach efforts, articulate the obstacles to a successful program, consider approaches to post-overdose outreach that can increase their uptake and impact among the target population. So next slide, please. So obviously this is number one, I have none of my own research or conflict of interest disclosures to make. There are no disclosures on my part, but also it's important to know that the views and opinions expressed by the participants attending ECHO are only our opinions. This is not UT Health San Antonio. This is not really anybody's thoughts except mine, having borrowed some of this material from Pronto. So next slide, please. So these are the folks. There's a whole team that we'll get to on the next slide, but the folks that are really instrumental to creating this was Dr. Alexander Wally, who is the principal investigator on the Pronto Research Grant. It's a CDC grant to really do a deep dive into the nature of post-overdose outreach. It's Massachusetts oriented, but it is federal funding to take the lessons from Massachusetts, really flesh them out and see what lessons and tools they offer to other jurisdictions. Tracy Green, who's an early mentor of mine, is also really instrumental to this. And it's important to note that there's a whole team behind this research that I'm presenting on their behalf. Next slide, please. So this is the team. You should definitely be suspect of anybody who just like without acknowledging a team takes credit for health research. It's always a lot of other folks behind the curtain. So in this case, this is the list, and it's probably not even a complete list. Next, and again, this is a Centers for Disease Control and Prevention grant that yielded this research. Next slide, please. So this is something that folks know, right? Which is that opioid overdoses are getting worse. They're continually getting worse. However, when we look at where they're getting worse, we see that the latest impacts in overdose nationwide are being felt by vulnerable populations, minoritized populations, Black, Brown, Hispanic populations. If you look here, Black non-Hispanic, right, had a marked increase in fatal overdose into 2022 when the data is up to. Hispanic had a marked increase, American Indian non-Hispanic, and actually went down a tiny bit for white non-Hispanic. So when we're talking about post-overdose outreach and saving lives from overdose, we're not only talking about 100 some odd thousand deaths a year, but we're talking about a changing landscape where minoritized and vulnerable populations are enduring the brunt of the increase. So this work could stand to help address that as well. So next slide, please. So this is the rationale for post-overdose outreach. And again, I want to acknowledge that instead of putting together my own slide deck, I just am presenting the excellent research coming out of Massachusetts with Pronto. Like the issue, right, is opioid related overdose deaths. One of the main predictors of a fatal overdose death is a non-fatal overdose death. So when you have administrative information, police records, EMS records that somebody has suffered a non-fatal overdose, you have an indication of the population at quite an elevated risk of a fatal overdose, right? So the opportunity is to use your knowledge about that non-fatal overdose to intervene on that person and to intervene on the people who care about them and are in their circle, to reach out to them, make a timely connection, and get them toward treatment resources, things that can avert the fatal overdose, right? So one of the things that is helpful about post-overdose outreach is it helps find hidden and underserved populations, right? If somebody has an overdose reversal but refuses to be transported to the emergency department because they don't want to engage with the ED, or they just want to get back to, maintaining their use of drugs, that event will still show up as an administrative record in police and EMS, right? The emergency department's not only always the best venue for prevention. Let's say they do get transported to the ED. It's not this like welcoming. If you've been to an ED lately, like it's not this environment that changes people's lives and gets them on a path to recovery necessarily. It's literally a clinical environment. And also there's a systemic stigmatization, especially racialized stigmatization that challenges engagement at every level, not only the post-overdose outreach level, the EMS response level, but the ED level as well, even informal treatment venues. So post-overdose outreach, if done well, can at least acknowledge or address or try to overcome that, right? And the intervention that we're getting at is home or location-based outreach. So I'm just reading the text, right? Following up with the survivor and the family, friends, in person or by phone. You can follow up at the residence or a location where the overdose occurred in the aftermath and try to make a connection with this person that suffered an overdose with the goal of stopping them from progressing to a fatal overdose, right? All right, next slide, please. Yeah, if you want to go ahead and just pan through, thank you. So this is just the way this data was put together. This is the research end of it. There was a comprehensive survey of active programs. We'll touch a little bit on that. The Pronto team did a lot of interviews of program staff, of overdose survivors, of social network members. They did an interrupted time series analysis to see if these overdose outreach programs make a difference. And then they enlisted the help of a bunch of experts to come up with best practices. And that's what this slide deck will show. So next slide, please. This is Massachusetts based, but this model, these results hold in a lot of locations. This just gives you a sense in where this research was funded, the spread of post-overdose outreach among the state, right? This is at the municipality level. It's not the county level. This is municipalities. And you could see that there was 23 municipalities in 2016, about the time I was about a year into being a police chief in Vermont by then. By 2019, it had gone up to 157. By July 2022, there were 245 municipalities. So again, at least in Massachusetts, but also nationwide, a big spread in the use of post-overdose outreach programs. But what I will say is there's a lot of heterogeneity, a lot of difference in what post-overdose outreach means, because it could mean so many different things, and we'll touch on that in a little bit. Next slide, please. So this is an interrupted time series. I can explain a little bit more about the methods in the discussion if anyone's interested, but they looked at as post-overdose outreach programs were implemented across Massachusetts, did it associate or correspond with a reduction in overdoses in the municipalities where they introduced post-overdose outreach? And the answer, it was a modest reduction, but it was a reduction, right? So this is not the final answer. This is not a purely airtight causal model, but they're just looking, an interrupted time series says you do something and what trends change after you do that thing. That's not a causal investigation. It's called an associational or an ecological investigation. So I'm a professor, love nerding out on that stuff. But the point is, when jurisdictions introduced post-overdose outreach programs in Massachusetts, after the event, after the introduction, it did have a modest association with reducing fatal overdoses. So that's a promising outcome, right? It's not, again, it's not the grand slam, answer all the questions outcome, but it shows at least things are heading in a good direction, not the wrong direction. And there's cause to believe that post-overdose outreach can get people linked with resources and treatment and make a difference. Anyway, go ahead, next slide. So there's a lot of different features of post-overdose outreaches that was investigated in Massachusetts, but there are some themes that emerge. It almost always involves police officers, 86% of the time. Almost always involves, a majority of the time anyway, recovery coaches, people with lived experience who can coach. Sometimes involved harm reductionists, social service workers, addiction providers, firefighters, EMT, clergy. Most of the outreach was in 1 to 3 days of the overdose that triggered the event. 51%, about half called before they visited, right? They didn't just show up at the door, but about half just showed up. They averaged about 3 attempts at outreach, 99%. So this is important. The whole thing is not only based around finding the overdose patient, but also working with family and social networks to build an environment that supports them as they try to get toward treatment. Most of them linked to resources in other communities. So we might not have treatment here, but right next door, there's treatment. You can go there if you need to. They were a part of a regional program. And if you just look at the rest of this, like 76% were grant funded. So this is preliminarily a grant funded effort across the country. And about half did not show up in uniform. We could talk a little bit about that. And they also, although cops came 86% of the time, police officers, they did not show up most of the time in marked police vehicles, right? There was also in Massachusetts the use of involuntary commitment, where you can get someone by law physically coerced and brought to treatment. That's a whole other discussion, but they did use that in Massachusetts as well. And over half of them conducted checks for search warrants. So, no, excuse me, not search warrants, arrest warrants. Anything that would, if we're going to this location, do we need to arrest the person who we're reaching out to? Is there someone in the household who we could arrest? That is something to give really serious thought to, because if you have cause to believe that people are doing warrant checks before they come to your house to offer you help, there's a huge incentive for the person on the other side of the door not to open it, right? So you got to think if this is the right environment to be doing not violent felony warrant enforcement, but bench warrant enforcement or misdemeanor warrant enforcement. Like, that's another important thing to think about when you're structuring a post-overdose outreach program. Next slide, please. So again, like, there's a lot of heterogeneity in what the teams look like, because this is not yet a science. It's being researched to find out what's most effective, but there's differences, right? Franklin County in Ohio had a substance use clinician, a paramedic, a plainclothes officer. West Virginia, they had 33 counties where they used peer recovery specialists, then police, fire, or EMS, a mix, right? Houston has pretty much a non-police response. It's a paramedic and a peer recovery coach. Tacoma, Washington had a firefighter, a nurse, a case manager. Again, a lot of differences in how the teams are structured. To foreground this, one of the reasons why police get involved is, one of the obvious ones is just this desire to help, right? To say, well, we're responding to overdoses, so we also want to provide outreach opportunities to try to solve the problem. But another important thing to think about is EMS data, EMS reports about overdose are HIPAA protected. Police administrative data about an overdose is not HIPAA protected. So the police can easily share that data with other parties to know where to go to conduct overdose outreach. So the question then becomes, because police have the data, and because it's not HIPAA protected, and because they can share it, does that mean they also have to show up at the door and be a part of it, especially if that might put people ill at ease? And that's a question to solve at the municipal level about the effective approach to post-overdose outreach. Next slide, please. This is what I was talking about, the police paradox, right? In many communities, law enforcement takes the lead in developing these programs. They had the idea for these programs. They have that access to the 911 call data. There's a lot of federal funding out there that's anxious to fund police overdose outreach. And for police, they just think of it. If I'm responding to the overdoses, I want to show up the next day and offer help. It's a natural instinct to help, right? But police are also the people that are making the arrests for drug possession, for drug use, for public disorder related to drug use, right? That just statistically has disproportionately affected the communities that are now being disproportionately affected by the rates of fatal overdose. There's that tension there. And again, if the police are, I'll be clear, as a former chief of police and New York City cop, if you have a robbery warrant, a violent assault, a felony assault warrant, a violent crime warrant, like, that person needs to be brought in front of a judge. But a warrant for not making the last court date, a warrant for petty theft or a nonviolent misdemeanor, it's not clear to me if the post-overdose outreach event is the time to enforce that warrant if your goal is to get them to open the door, engage, link to treatment, and get on the road to recovery, right? And that's something that this paradox brings to light that has to be reckoned with. Next slide, please. Post-overdose outreach funding right now has a lot of opportunities, right? The CDC is funding it. SAMHSA, Substance Abuse and Mental Health Service Administration, is funding it. The Office of National Drug Control Policy is funding it. The National Association of County and City Health Officials is funding it. And big question mark, there's a lot of opioid settlement funds making their way through all 50 states, millions and millions and millions of dollars at each state level. That can be used for post-overdose outreach funding with a lot fewer restrictions, actually, than a lot of the federal grant funding that we see in the list above. Next slide, please. So we'll go back to this at the end, but there is a best practice guidance for post-overdose outreach briefing product that Pronto created as part of its funding. That's the QR code for it. If you Google it, it's easy to find. But we'll go ahead and put this up at the very end of the presentation. Next slide, please. So these are the folks that develop the best practices. Again, it's like one of the former US drug czars, a lot of researchers, people with lived experience. Now, to be clear, what you're not seeing on this is police officers, right? And to be clear, like after the best practices were authored, they were sent to a former chief of police from the NYPD. They were sent to me. So the initial group is these folks. And then the products were sent for comment and revision to active law enforcement and folks out there in EMS, et cetera. All right, next slide, please. Again, so one of the things to keep in mind, at least this is the result of this research, is this is a public health issue, right? When you're doing post-overdose outreach, the whole point is to frame it as, although the police may be present, this is an acknowledgement that the public health approach is what's being emphasized during the visit, right? And the goals are as follows, like I said earlier: prevent fatal overdose, connect survivors with harm reduction, evidence-based treatment and recovery support. And then you want to engage people that wouldn't otherwise find a link to these services. If somebody is going to harm reduction on their own every day, if somebody's on the road to recovery, if somebody has made the decision to seek recovery, if somebody has a very supportive family network that's edging them toward recovery, like, it's great to do post-overdose outreach for them, but you really want to reach the people that otherwise wouldn't be making this connection. And that's the best potential of this. And again, if somebody has overdosed, they statistically are at elevated risk for fatal overdose. It's a great intervention point. Next slide, please. Program staffing. You need familiarity with the local resources. You need local people doing local work. This is an inherently local, individualized process, right? You can't come in with some statewide or even necessarily countywide approach. You need to have local resonance, right? Evidence-based care prioritized. Evidence-based means connections to medication for opioid use disorder, connections to evidence-based harm reduction strategies. Lived experience can be a strength. To have a peer coach or a peer recovery person or somebody with lived experience knocking on the door saying, I know there's an EMT here, a police officer here, but I went through what you're going through and I want to talk to you for a few minutes. That can be very compelling. Trauma support is needed for the overdose victim and the family. It's a fundamentally traumatic event to almost die of an overdose. So this all has to be trauma informed. And overdose survivors should advise program staffing. You want to create this product of post-overdose outreach with the knowledge and experience of overdose survivors in mind to make sure it resonates, right? And then, you need to have training best practices. Again, local resources, the right amount of informed consent as necessary. And then the topics are ones we touched on already: overdose prevention, the nature of SUD, what kind of treatment you can get, links to harm reduction, trauma-informed care, stigma, data safety, self-care. I'm sure the audience is pretty familiar with this. Next slide. And again, law enforcement personnel, to be thoughtful about. I'm generally supportive of police participating in this, as, again, someone who was a police officer for 23 years and a professor of medicine, but we really need to give some thought to how it manifests, right? Meaning, consider community relations, consider trust building, consider overcoming obstacles to trust. You want to minimize actual perceived coercion by law enforcement. Open up, police. Like, that's not a way to get engagement. Or open up, like, if you don't turn this around, we're going to get a warrant to bring you in front of a judge and force you into treatment. Like, that's not going to get the door open. And you want to have the police, from a position of humility, say, we're here to help, but in this encounter, this is a public health oriented encounter. My public health colleagues are going to take the lead here. Like, that's important to acknowledge. And again, like, you want to be able to have facility with de-escalation and crisis response. These are inherently, like, stressful, tense environments. People came close to dying during the last visit. So just knowing how to handle and de-escalate that environment will help with engagement. Next slide, please. Visit procedures. I do believe that unmarked vehicles, soft uniforms, and plain clothes, number one, protects privacy. Number two, keeps the curiosity of the neighbors at bay, conveys that this is about linkage to care, not enforcement. saying why police are here. We're here to help. We have the data. We're sharing the data with our colleagues. That's why we're knocking on the door. It says avoid carrying firearms. I'm being candid and I'm saying nothing I didn't say to the grant holders who did this research. Police are not going to stop carrying guns on duty. That in Texas, where anybody can get a gun with no permit, no training, no licensing, no nothing, the police are not going to leave their gun home that day. So that is part of the recommendation. I'm putting it in to have fidelity to what they came up with. Me, if I was hearing this as a serving chief of police, I would strike that bullet. No pun intended. But on the other hand, you don't want to make this a coercive, menacing law enforcement environment, which is why you're using unmarked cars and plainclothes. And again, give a lot of thought to what role arrest warrant execution, if any, should play at the scene of a post-overdose outreach. I spilled the beans by saying I make the distinction between minor bench warrants and minor misdemeanor warrants versus felony warrants, but you have to give some thought to how that's going to play out if you're doing one of these programs. And if someone says, listen, I mean, this is another way to do it. If the person has a bench warrant, you can say, I'm not bringing you in on this minor warrant today, but you need to clear this warrant. Otherwise, you could be taken off the street at any time. An arrest actually increases exposure to overdose because people suffer withdrawal, their tolerance goes down. So one of the things you can do is not necessarily make the arrest for the bench warrant or the minor warrant, but help them clear the warrant. Say, we can hook you up with resources to get you into court to clear the warrant so you're just not arrested at some point, but you're doing it in a more thoughtful way. And then next slide, please. So again, you also want to give thought to the police have the data. The data is not HIPAA protected. That makes them a very vital resource, but that doesn't mean that the police should be at the center of this or leading it or foregrounding it or taking an enforcement approach. So we have to be able to take this administrative data that points us toward where we need to knock on doors, but do it in a way where it's not necessarily now another opportunity for enforcement or centered as a police rather than public health oriented approach. Next slide, please. Next slide, please. All right, so I think we're getting close to time. I'm going to leave this up so folks can take a read. But again, post-overdose outreach offers the ability to reach a very hard to reach population. It happens at just the right time, which is a few days after an overdose where somebody has probably given a lot of thought to what happened and if they want to make a change in life. It helps us reach populations, for example, Black, Brown, Hispanic populations that are getting hit the heaviest with overdose these days. It also allows us to bring public health and harm reduction resources that are literally directly to a person's doorstep. You want to figure out how to integrate the police in a helpful and constructive and added value way, rather than a way that introduces tension or makes people want to keep that door shut. You want to invoke the lived experience of survivors to make sure it's effective, not only in planning it, but maybe even knocking on the door as a peer coach or person with lived experience to get that door open and get people engaged. Next slide, please. So this is, again, the QR code for the whole document. It covers all the stuff that I talked about today. You can use it for a reference, pick the best pieces that work for your local agency. And I'm sure the folks at Pronto would be thrilled to know that their ideas have taken hold in other parts of the country. I'm sure they'd be happy to talk about their research, to offer some assistance and give advice based on what they've learned in Massachusetts. And again, I want to acknowledge that I've had the privilege of presenting their work. So I'd like to acknowledge the effort they put into bringing this to us. That's all I have.
Thank you so much, Brandon. This was an amazing presentation. I'm sure our learning community here have some questions or comments.
I've answered all the questions. People are sold. They're going to do it.
Yes, Jeremiah.
Thanks for that, Brandon. Really interesting. I had one question, kind of a specific operational question on that, and it was regarding on your thoughts on giving advice on how to clear a warrant. Was that would you imagine that to be something that a participating officer should do, and if the officer's there, or be the kind of the behavioral health peer? Just wondering if you thought in
Yeah,
that.
no, that's a really good point. And I think a few things about the warrants. First, I know for a fact from research and my own experience that police, although it says, like, if you print up a warrant, it says, like, by the authority of Judge Jones, you are hereby commanded to bring this person to the court. Like, that sounds very ominous. I think that ominousness does count for like a rape warrant or a robbery warrant, but police will tell you time and time again, they've elected at the right time to not always enforce a very minor bench warrant. So police have and no one's come to them and said, damn it, you let that retail theft suspect go because they missed their court date. So first, whether it's research we've done in Arizona, whether it's research we've done in St. Louis or Indianapolis, police don't always enforce minor warrants. The wisdom behind helping them clear it is if a person's walking down the street and let's say whatever, they get stopped by the police for some reason and they get their name run as a victim, as a witness, even as a medical patient, and they have a warrant. Now, bam, they're off to jail in the court, like in an uncontrolled, unplanned way. So what you want to do is if you have a serious warrant, like don't give legal advice, tell that person to get a lawyer, right? But if it's a minor warrant, oftentimes the police can work with the court to say, if you show up at court this day, if you show up at court this time, or if you have a local public defender that you've worked with on your prior cases, call up your public defender, talk to them about clearing this warrant. So my opinion, and again, this is not legal advice, if I were the police officer at the post-overdose outreach scene, I would say you have a warrant, find your public defender who represented you or your defense attorney on this case, call them and work with them to clear this warrant. The public defender can easily call up the court and arrange a date for them to appear. Does that make sense, Jeremiah?
Yeah. And actually, I mean, some way I was just wondering whether you thought the person who having that exact conversation should be the officer or the behavioral health person.
I think so honestly, I think it sounds, anyone could say it. I think when the police say it, it comes with the assurance that this is like the law enforcement officer telling me how to clear this warrant. And it also, in my mind, conveys the fact, like, from the cop's mouth, we're here today to help you with your substance use disorder.
Yeah.
It could arrest you. I'm not, but I'm giving you the tool necessary to take care of it without even involving me. So that's like a really good faith approach.
Yeah. I have a follow-up question on that, but I want to let anyone here, in our community ask a question first, if anyone has one before I go with it. Well, while you all reach for the raising hand button, I'll go ahead and ask it then, which is the question of if a warrant exists, so say that, the police are going to go, all right, and the partners are going to go make an outreach call, and they do the warrant check, on the computer first, and they say, okay, so, Jeremiah's got this like minor bench warrant, say. The next question then is basically, would you say, all right, that's fine, go out, don't enforce it? Or would it be like, let's, on this one, since there is a warrant, let's like just not send an officer on it at all. Let's just send our peers out to do it. And
so I think that's ultimately a feature of the individual program. I haven't given much thought to what the optimal approach is. I think that just saying, well, cops are going to participate so first of all, you can make the case that cops don't need to participate in this. They could share the data and step back. But if they're going to, you can't kick the can down the road. We're like, well, we're going to go this time, but not that time. Like, I think if you're coming in plain clothes and you're coming in an unmarked car and you have a thoughtful approach that you can abide by to executing warrants or not, like, it's fine for the cops to go. I worry that like you just kick the can down the road when you selectively go based on the warrant. But that's my first blush, Jeremiah. If you gave me that question in advance, maybe I could have thought about it for a day.
Yeah.
But you could tell I'm impatient for police to figure out how to get this right and not just like ad hoc it.
Right.
So I'd love to have something more systematic come of it.
Well, one of our friends in Fort Wayne Police in Indiana. This is, of course, Captain Kevin Hunter's program. This is a solid person to learn from. He's ultimately created up a thing where their program they don't go when there's a warrant. They hand over because they've built up a really good relationship with their outreach partner organization. And so that's what they've come up with. So that as an example, which I just
No,
find
that's an interesting way to get around cops' tension. Well, it's a warrant and I'm commanded to take this person. And okay, I'm just not there. Like that's interesting. That requires more research, but that's an intriguing idea.
Andrea, I saw your hand up.
Oh, I just had a question. Does that imply paying that process that Brandon was describing, paying a fine? Because I know there was recently a program, I think it was in Oregon, where people who were found using substances, they would pay like $100 fine and then they will commit to go to a program. So I am thinking that for some people paying that amount of money could be a lot. So in this case, is it the same? Do they still do that?
Well, when Oregon decriminalized, and now they're taking steps to recriminalize, but when they decriminalized, the criminal offense became a civil offense. And instead of getting arrested or getting charged, you got a ticket. And if you called the number on the back of the ticket, which is a 1-800 number, and you submitted to a health screening where you answered some questions and or offered outreach, then that was it. Nothing else to be done. You complied with the requirements. If you didn't call the number, then you got $100 fine. And to my knowledge, that fine was almost never enforced for very, very few. One of the frustrating things about Oregon, and it's a whole other conversation about the implementation. And I think it wasn't well implemented, to be honest, but very few people called the number. A lot of people got the $100 fine and almost nobody paid the $100 fine. For the reasons you cite, like if you're out there on the street, homeless or poor, or you're feeding a substance use disorder, the idea of like, calling a 1-800 number might hold very little appeal to you, right? And then the idea of paying $100 fine is almost impossible. Right, but some of these warrants might be for court cases where people have fines. Again, like it's not the job of the police to collect on that fine during this visit, right?
Well, that has been a wonderful discussion. Thank you again so much, Brandon. In the interest of time, we will now move on to the next part of our session, but please keep the questions coming and Brandon can take it in the chat. Taylor, if you could please share the announcements from the BWell program. Do you have a difficult case that you or your team have encountered? CSTAT offers you the opportunity to present any challenge your organization is encountering and receive expert feedback from our hub members. There is no need to prepare a formal presentation. We will provide a case form to help you with your case presentation. Please email us at cstat@ithaca.edu. Next slide. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics via our team of experts. To request technical assistance, please complete an online request form at this address, and we will be sharing that in the chat as well. Next slide. Join CSTAT for our session titled Mitigating Grief and Loss Post-Pandemic. This will be happening on Tuesday, May 21st. You can use the link in the chat to register. Next slide. Our next session will be on June 13th. You can please join us for the session, and you can register on our website to, you can get to our website to register for the session. And with that, we will move on to our case. Taylor, if you can please share the case form, and Vanessa, you can take it away when you're ready.
Thank you. Okay, so my name is Vanessa Fears. I'm a social worker with the Department of Behavioral Health with Bexar County. Like I said earlier, what we usually do is jail diversion. So I usually will conduct screenings within the jail. But the questions today for you guys would be, what other strategies or resources did we miss within this case? The setting was in county jail. They were referred by felony drug court for a substance use disorder evaluation for a local residential treatment services with lifetime recovery. The strategies that I used in this encounter was motivational interviewing, a person-centered and solution-focused approach with strengths perspective. So usually the standard operating procedures with these encounters are through Zoom, virtual evaluations. that are conducted by, we work with the Office of Criminal Justice and programs that send the referrals. So sometimes they can be community referrals as well. So the person in this study that we'll be discussing, their substances that they were using were heroin and methamphetamines. Some things about the person, they said that they were employed part-time, that they were living on their own before they got arrested. They didn't identify with any race or ethnicity. And I loved this because they defined themselves as human, and I totally agree with that. And they also identified as transgender. So client was guarded. So the barriers that I feel like would be encountered, or that this person faces, was that they were very guarded and unsure of being open and honest. There's a lot of barriers that she's facing due to possible discrimination in facilities that are designed exclusively for males. She also mentioned that she was having some symptoms with withdrawals when she came into custody from using heroin, and then also was very upset about them shaving her hair because she had a weave that was sewn in and it was about $500. And so she was pretty upset about that. And I think one of the main concerns was not having clothes that she felt would be appropriate or comfortable to enter into treatment with when she was released. Some things that went well during this encounter was that I acknowledged her by her non-government name, right? And used she, her pronouns. I also expressed a lot of empathy as she was talking about her withdrawals in jail. And I also let her know that, well, after the interview was after the screening was conducted, I let her know, after I told her that she met criteria, that I would reach out to these facility that she was going to be going to see if I could help arrange somebody getting her some clothes that she felt more comfortable entering treatment in. What would I do differently if presented with this scenario again? I should have, and I am like making attempts to call different agencies so that, and figuring out some other resources. So when they're released from jail and admitted in treatment centers, like what happens, right? What do you think success might look like for this case? I think having MAT inside the jail, like not just for pregnant women, but for anybody that's coming in with withdrawals from any type of opiates. Sensitivity and inclusivity training in the detention centers. You know, like I said, when they shaved her head, she was very upset about that. Having clothes or some type of backpack with resources for people leaving the jail that might need more support than others. The continuity of care and resources designed specifically for LGBTQIA+ populations. The referrals made or options for the referral was felony drug court, lifetime recovery, and then there will be a continuity of care provided by recovery coaches at lifetime.
Thank you so much, Vanessa, for bringing this case to us and presenting it. I will now open up the floor for any questions or comments from our learning community here.
Can I say something? Probably not too relevant, but just from my point of view. Oh, how horrible to just do that, to shave a person's hair and treat a person like that. Like if someone came and shaved my hair, I would have a heart attack. That is so invasive and disrespectful. That to me is like a violation of a person's dignity, in my opinion. I might be wrong. I'm not an expert. I'm just saying this as from the perspective of a human being. That's all I wanted to say.
I completely agree with you. Like it takes time to get the hair that you desire, and then for somebody just to remove it, and it's so expensive as well, and it just kind of takes away your dignity as a person and, like, you know, that humanity.
Jeremiah?
I guess my question is sort of a follow-up on that, and then another one, which is basically why, like, what do you have any sense of what the rationale was for the head shaving? And also, are there no co-ed residential treatment options locally?
As far as state funded, right? There is not like a co-ed currently. And so I have talked with the place that she was going to find out like what is that criteria, like how does that look for other people that are entering. And basically what they said is like it's okay if they're in the process of transitioning, however if they do not have the male genitalia, then they would be sent somewhere else. If they have already completed the whole process of transition, then they would go to somewhere else. But if they were like halfway, then that's okay.
Wiki?
I would suggest getting the client in contact with the Pride Center San Antonio. They can provide some really excellent resources. They have a peer group for trans people and trans allies, and that may be a really great spot of resource and safe space. And I know just from working with them that they also have several people on staff who have substance use disorders who have been through treatment. And so they not only have safe space, but they also have people who have, may have experienced the same issues that you're highlighting.
Awesome. Thank you. I know about the Pride Center, and I don't know why that just didn't pop up in my head, because I was like immediately, how do we fix this? Right.
Yeah.
So thank you, Vicky.
Sure. My email's in the chat. I can connect you with the CEO, Robert, if you would like.
Yes, that would be awesome. Please.
Okay. Yeah, shoot me an email.
Okay.
Okay.
Thank you so much. Any other suggestions or questions for Vanessa? Or if you have had a similar situation or a case, please share your experiences.
Just was gonna ask to Jeremiah in this case and Brandon, who are the experts? Are we at some point like making changes in some local or state organizations in terms of handling differently people from the LGBTQ community? Or if you guys see that like way like far-fetched, that's still not happening, realistically speaking?
I mean, I have some thoughts, Brandon. You might have a better sense of the landscape.
I think the landscape, I was thinking about that too, and I'll be summarizing this case. So I think that that there's tremendous difference, and there's not a national there's an understanding, right? First of all, you don't want to, in my opinion, just completely other the LGBTQ community by saying, well, we have a system for cis hetero folks, but you're LGBTQ, so therefore you must be different and need a whole different thing. And so you don't want to just say, by virtue of your identity, like you're different than the other folks who need help. But you also need to understand two other things. There are important differences as we figure out how to integrate folks better into society and acknowledge their dignity and rights. And the last thing is, it's not all the same, right? Like there is no cookie cutter approach to successfully engaging with the trans population, right? What might really matter in terms of the comfort level or what kind of dorm for one person to go to is going to be different than another, right? And so number one, I don't think we're anywhere near close to like figuring this out or getting it right. But when I do, I think it'll show us like how much diversity of need there is and how individualized a good outreach effort and a good connection to care effort is. And if the goal is to actually help folks and not just like disguise punishment as care, you have to go through the trouble of making the right connections and really assessing their needs at the individual level. And then very lastly, a lot of this is going to be trauma informed, right? Because what brought the person into substance use is trauma. Being a trans person in society is just all about trauma these days. And then being in a criminal justice environment as a trans person contending with substance use, like super traumatic. So yeah, I'm sorry, I don't have like an optimistic answer, but I think the challenge is really acute.
Thank you.
Yeah, I think I would just basically go with that. I mean, when it's just shocking to consider how much, and everybody here knows that, we're talking about stigmatized audiences getting, often stigmatizing treatment. Like Brandon said, treatment care, that's often just a punishment in disguise, and not taking into account taking the trauma informed thing, looking at all the deep root causes, or paying attention to the area groups that have disproportionate experiences of mental health and substance use disorder. And yeah.
I see a comment here from Stacy. At Nexus Recovery Center in Dallas, we take transgender females, no questions asked. It's invasive and inappropriate to ask a transgender individual what stage they are in the transition. Asking about genitalia should be off limits. Completely agree. Thank you so much, Stacy, for sharing that resource.
Thank you. I do have a follow-up if y'all are wanting to hear what happened. So after I had that interview, I called Lifetime, their admissions, I called drug court, I called the director of residential counselor. I made as many contacts as I could and let them know, like, hey, this person's going to be coming over there pretty soon. They're very concerned. The only thing that she was super concerned about was no clothes, and like the stuff that she went into jail with was not appropriate for her to be. She wasn't comfortable going to Lifetime with that. And so the admissions person told me, okay, well, we'll do whatever we can to figure out how to get this person some clothes, even if I have to go to the store and buy her something brand new, like I'm gonna do it. So then after she entered treatment, I found out that the case manager with felony drug court, they went over there and delivered some more clothes for her size and new shoes to help her over there temporarily while she's staying over there. So I thought that was pretty cool.
Thank you. Any other comments on this case before we wrap up?
Well, I was going to say, Shreya, if someone in the audience can tell us how their organizations handle persons for that particular community in similar cases, that could give us a good point of discussion also.
All right. Brandon, if you could please summarize the case for us and some of the recommendations that came up today in the discussion.
Yeah, thanks. I think that the discussion actually did a great job of offering a summary, which is that these criminal justice and treatment and linkage to resource programs are always not a one-size-fits-all process. And in the case of a person who is transitioning, who has a transgender gender identity, like that one-size-fits-all myth is completely blown out of the water. Because you not only have the regular issues of meeting someone where they're at in terms of the trauma of substance use and what brought them into the setting, but then you have like really acute issues of identity, of safety, of belonging, of where do I fit in this community, stigma, and all of that. And it's not just going to be a new bucket that we create for that type of person, right? It has to be this highly individualized process where you figure out where the person's at, what their needs are, and it's not going to be the same simply because they're LGBTQ or trans. It's going to be individualized based on where they are in their arc of their life and their trauma. And again, like you can just shake your head and say, this is too complicated. The law is the law. I'm going to shave your head and do it. But again, I think that's just masquerading punishment as connection to care. If the goal is to keep and sustain engagement and break the cycle, we have to figure out how to thoughtfully engage and reach this population. And it's not a homogeneous population. I mean, I think that's the point I'd like to stress too. So thank you.
Well, thank you so much. And thank you again, Vanessa, for bringing this case to us. Please feel free to come back to us to share any updates you may have on how it went for this patient. And thank you all for joining today's Echo. As a reminder, to earn continuing education credits, please complete a post-session survey using the link in the chat. If you would like to present a case, please email the Bevel, Texas team. We look forward to seeing you at our next session on Thursday, June 13th at 11 a.m. Central. Thank you and have a wonderful rest of your day. Bye-bye.